Imagine,
Imagine, yeah. If I start counting.
So we've started recording, and Jananga will take over from there.
Okay.
No, we'll first start with ground rules. Our CEO was supposed to be here this evening. We welcome, unfortunately, I think she's having challenges on her end, so we'll represent her on our end. Tonight is the Kucha nights for the divisions, and we hope this will be done every Fridays. It's a relaxed way of presenting, using more images rather than lots of PowerPoints with a lot of writing. So we hope you'll enjoy this evening, and you'll learn a bit of what Nakuru County has been doing in terms of engaging Nakuru division in terms of engaging with Nakuru County and Baringo to ensure that we curb COVID within our region. So tonight we have the COVID-19 county experience sharing from Nakuru County. I'll be presenting what we have been doing in Baringo within the community, and Anthony will present on what they have been doing at the county referral hospital. And Yvonne Decker will present a bit about Naivasha sub-county, and we have a county health management team representative. Jananga will give the full in terms of the program. Jananga?
Yes.
Brief on the program.
Oh, okay. Good evening, everyone. You're welcome. I'm Jananga Elizabeth. I'm a pediatrician and treasurer, Nakuru Division. So I'll take you through the program. We'll have welcoming of the attendees and the panelists, and we'll have the speakers. Speakers will be Dr. Anthony Wainaina, who is a physician, and the lead team leader of the COVID-19 in Nakuru. Then we'll have Dr. Joy Mugambi, who is our physician and our KMA chair, who is also going to take us through the experience in Baringo. We'll have Dr. Yvonne Decker, Naivasha, who's going to tell us what they are doing in Naivasha and their experience in Naivasha. And then we'll have a discussion, Q&A. And then lastly, we'll have a closing remark from our former chair, KMA Nakuru, Dr. Otara, and our incoming, we are giving him votes, I hope, vice chair of KMA National. Yes, that's how we are going to do this evening. I'm supposed to be moderating with my namesake, Dr. Elizabeth Gitau, but she's still having issues logging in, and I hope she will get us as we go ahead.
So as house rules, on the other side for the attendees, we have the chat and the Q&A on your panel. In case you need to air any chat issues to discuss that are not questions, do click on the chat and post your question in there. It will look like this to either everyone or to a panelist that you want to aim the question, the discussion at. You can also click on the other side on the Q&A and post your questions, and the panelists will respond to you. We have a larger array of panelists as far as we are 3 speakers. We've got our National Executive Committee with us, and we do have our colleagues who are also executive of the Nakuru Division and county representatives who will be there. So do post your questions and any discussions on the chat. The Q&A section looks like this. Post it there. We'll either answer it live or we will respond to you on the Q&A section as an answer. So thank you very much. We have been running this mental health series on Tuesdays, and we hope that you can also join us during our mental health series. which are held on Tuesdays. In case of any mental health issues that you need to reach out, that's our office number at the national level, where you can reach out and you will be linked to someone for help. So thank you, Jananga. I hand it back to you.
Oh. Welcome and good evening again, everyone. Welcome to our Pecha Kucha Friday presentation. Today, we are going to have the Nakuru division sharing their COVID experience and how they have been tackling the COVID in Nakuru division. And our first speaker will be Dr. Joy Mugambi. Dr. Joy Mugambi is a physician consultant at Eldama Ravine Hospital. She's also the current chair of Nakuru division and outgoing assistant secretary of the national body of the KMA. Joy, please, the floor is yours. Give us the Baringo experience. And she also share.
Before I go ahead, we have Madam President here, who was to do the opening remarks before we move on.
Thank you, Joy. Good evening, everyone, and thank you very much, KMA Nakuru Division, for starting off this inauguration of Pecha Kucha and giving us, the county roundup of what's happening on the ground. And I think that's really the essence of what our divisions are meant to be. They are meant to be the beacons at the county level. I think on matters county, there's been a lot of talk of challenges of county preparedness. And I think what better way for us to input into the preparedness than by the divisions interacting. So KMA at the national level has been engaging in the COVID response in very many various aspects. As the KMA team itself, we have a KMA COVID Response Advisory Committee that meets every Wednesday, and a lot of the input, or rather the output from that has been several advisories, which we continue to share with Senate, with Parliament, with government, and we must admit that several of our recommendations have actually been listened to and implemented. On the other level, we have also been involved as members of the MOH COVID Task Force Response Team. Our SG, Dr. Kigondu, sits in the capacity building and HRH committees. So inputting into what's happening on the HRH level, training, and I think you've all seen our COVID training, which is available on our website, and actually has really reached out to very many people, even beyond the country. In the COVID Response Committee as well, I sit in the case management team. So again, reviewing the various protocols. We, as KMA, also represented at the National Coordination Center for Quarantine and Isolation Facilities, which is seated at the KMPDC. So that has been one area in which I personally have been sitting on and coordinating quite a bit of the functions at quarantine and isolation. We are also sitting in the Resource Mobilization Fund, and our CEO, Dr. Gitao, is representing us very ably right there, and we'll be hearing some pretty good news coming out from there. On the psychosocial support side of things, Joy has already mentioned our Tuesday weekly webinars, which have had amazing attendance, even going up to 3,000 on certain days. So again, inputting into that and even going beyond that and partnering with the Nurses Association, the clinical officers, part of it is working towards a wellness call center. So there's actually very many areas at the national level that we are continuously engaging in. So this input from the counties is critical. And I think you're all aware that there was an extraordinary session of the national and county government's coordination to COVID response held at State House on the 10th of June. And during that meeting, which was chaired by the president and attended by the county governors and top leadership, it was resolved that the Ministry of Health should extend technical support to county governments in order to enhance the capacity and preparedness to respond to the pandemic. So I think input from each of the counties, like now what we are doing in such sessions, that will help towards such responses. KMA will be represented on this advisory committee. So thank you very much, everyone, for joining in, and thank you, Team KMA Nakuru Division, for starting us off. Karibuni.
Thank you very much, Dr. Kitulu. I'll go straight to my presentation. So what we have done as Baringo County, where I am in Eldama Ravine, we noted that we needed to do something. We are from a very rural community, and we needed to tackle COVID from where we were at, rather than wait for solutions coming from very far up. But we needed to engage with our communities and see what we could do best. Baringo County is the small yellow dot that you see over there. We are white when you look at the COVID map, because yes, we have had very good neighbors who have done quite a lot, and that is Nakuru County, Eldoret, and the other counties that surround us. When COVID came in, we were as slow as the tortoise that you see there. This is Baringo County. This is what we have. We have lots of tortoises on the road, and they are slow, yes, but we had to do something. Yes, the response to COVID at the very beginning was quite slow. We did not know what to do, but we started off with training our staff in terms of awareness on COVID-19 and the community. A lot that you hear about Baringo is Baringo clashes, water shortage, teen mothers. A lot was being heard about floods. We had a lot going on. At the same time, we had to prepare the community for COVID, and we also had to prepare the community for all other essential services that are in place. Within the facility, we ensured that we triage at the entrance. You can see our security guard with a book that registers everyone at the very entrance, using one entrance into the hospital, and recording all data that of the people who are coming in, with one visitor getting into the facility. We also do temperature checks at the very entrance and a brief history, where there is a nurse stationed just right after the gate with a hand wash area, which is not very far from where this gentleman is standing. And once she has done the temperature check, there is a record book that she records and ensures that she has taken a brief history. Those with cough, difficulty in breathing, walk to the left. There is an area where we hold them and screen them further in order to ensure that we are not having cases of COVID. The other essential services are offered to the right, and the patients are going to our usual outpatient, and they are either triaged to the services that they are going in for. Our facility is very small, but the services are all provided in one facility. These are our essential services which have continued. The children are still coming into our clinics. Once they are triaged, we do examine them. Simple PPE of, yes, a simple surgical mask, but where aerosolizing procedures are concerned, yes, we would mask our staff with the N95s. They are available. They can ask them from the nurse in charge and they'll be provided. We, other than the essential services, we have this cough holders area where our member, one of our members within the Lions Club, provided us this COVID screening box where we screen our clients using this glass box that's got some gloves popping out. And I think Anthony will talk more because we got two. One was brought into Eldama Ravine and another one to Nakuru County. And they've modified further in partnership with Egerton University and created a better model than the first model that we created, which had used gloves of the usual cleaning gloves that we have, the heavy duty, which are quite big and are very difficult to use. So this is our holding area. It has one room and you can easily hold a patient here even overnight. It has bathrooms and toilets at the end there. And this is where we collect our samples and take histories from. There is usually a desk out here and we are able to examine using our simple small holding area. Once we have cases that need isolation, there's a facility outside the main facility that has 8 beds and can be able to accommodate 8 clients at the same time. So first of all, we used to test using our usual PPE, the hazmat suits, the N95s, and for each client that had come at that time, this was the time when there was so many travelers coming in, and we had to screen the, from calls from the community. So we used to use these hazmat suits and they were running out fast. So the introduction of this booth really made life much easier. We use less expensive PPE because you're using minimal PPE, just your usual either surgical mask or your N95, so long as you're within the glass booth and the client is outside. This area is later sanitized and disinfected. At the community level, we've had testing and quarantining of clients who had traveled in from Mombasa and outside the country. So we had to even get out into the community and do testing, or the homesteads and do testing. And this really helped because the community also helped us contain the ones who needed to be quarantined for 14 days, rather than them walking up and down into the facilities and us being overwhelmed with the work of containing people within quarantine centers in the facilities. So we did more of community quarantining rather than facility quarantining. Most homesteads have facilities that people can hold their relatives, so that worked out for the teams that came in earlier and needed to be quarantined. This is us in the community. You can see we are accompanied by the chief, community health workers, and our lab technician. And we do have even community health workers who have been trained and have also been assisting us in terms of tracing and tracking our diabetics and hypertensives and all other essential services, and the ones who have missed clinic to be able to be referred back to the facility and linked to the nearest facilities. This was a community education. We are also having an upsurge of TB. I think either it's because of the targeted questions of cough and difficulty in breathing that we are also including the screening of TB for any patients who come to the cough holding area, because yes, TB has been a menace in Baringo. So this was a home visit to a home where we had 2 cases of TB to screen the clients there. These are our community health workers. We'd gone out into the community. This was way much earlier before we started all masking. In the very early months of March, trying to educate them because we felt that there was need to start training them to be able to link the diabetes. Just in an event, we end up having a case of COVID in the country, and that is when March came in and we ended up having our first case of COVID in the country. And this has really been of benefit because these community health workers are now linking the diabetics, hypertensives, and children who need immunization back to the facility or to the nearest health center, and they are assisting us check those who have missed their appointments, and being able to facilitate their linkage and facilitate their refill of medications for those who really do not need to come to the facility. So I'll say thank you and hand back to Jananga. We can beat non-communicable diseases by working together with the community. Thank you.
Thank you so much, Joy, for that nice presentation. Thank you for sharing with us the Baringo experience, which is a lovely community experience of what is happening on the ground. I have a question. I was thinking if I can give you a question, we can do it after all the presentation. I think we can do it after all the presentation so that we cover it all up together. So I'll welcome our second presenter. That will be Dr. Anthony. Dr. Anthony is a physician consultant in Nakuru, level 5 hospital. And he's the team leader of the COVID-19 in Nakuru. And want him to share with us the experience in Nakuru, because we've had a number of cases, what Nakuru people, what Nakuru level 5 is doing, and how the experience has been so far. Dr. Anthony Wainaina, please take us through. Welcome.
Can you hear me?
Yes, we can.
Okay. I'm going to make a short presentation on the experience of Nakuru County Referral Hospital. It's a picture story on setting up an isolation area and treatment of patients. So, can you see my presentation?
Yes, we can, Anthony.
So, this is a picture story. This is the secondary triage area at the isolation area. This is an area where after patients are triaged at the primary triage area, which is at the casualty, they're sent here to the secondary triage area. It's outside. So on the left side is a waiting bay. The waiting and secondary triage area, it's located outside for maximal airflow, and all suspects are provided with a free mask at the area. Then there's a testing area, which is adjacent to the secondary triage area under the tent. You can see the isolation wards at the background. So this is a suspect case. Suspects are enter through a dedicated path to the isolation wards. They don't use the same entrance as the staff. So the first picture is the entrance to the wards. Then second picture is at the end. So they enter the wards. And then on this third picture, that is the isolation area. The isolation area we use for the suspect, we have separate rooms for each suspect. So these are self-contained isolation rooms, and they have everything set before the patient goes into the room. So we have 7 self-contained rooms for suspects who are awaiting their PCR results. The rooms are prepared beforehand with all the essentials needed by the suspect before they are admitted for isolation. So on the third picture, this is one room with a chair, a bedside cabinet, and a bed and a washroom on the far right. And the fourth picture is another room. The second picture is a corridor in this corridor, so the donning is done outside the isolation rooms, and then you can go in to the corridor. So for the stable patients, we can serve the meals from the corridor outside the rooms, where they may pick from their cabinets, which are located outside the doors. You can see some cabinets outside the doors. And linen may also be dropped at the cabinet for the stable suspect who is able to make their own bed. So we can drop linen there. So this is to protect the healthcare worker mostly. You can do clerkship from the window if the patient is stable and maybe asymptomatic or just has mild disease. This is the doffing area at the isolation. So at the end of the corridor, we have the doffing area where you remove your PPE. We have foot baths with 0.5% chlorine, taps. You can see two taps there, one with 0.5 and the other with 0.05% chlorine. The 0.5% chlorine is used to clean the gloved hands, and 0.05% chlorine to clean the ungloved hand, your skin. Then doffing is done with the help of an assistant through an observation window, which is on the right, through which an assistant can aid with the doffing process. And there's a bucket where reusable goggles can be dipped and be contaminated with 0.5% chlorine. Disposable PPE is discarded in a red linen bin. So for the confirmed case, we have two wards. There's a separate male and there's a separate ward for the women and children. And this is for management of moderate cases where we have piped oxygen. So there are aerated areas with beds well spaced for the confirmed cases, and they have oxygen and a lot of air passing through. So we have an intensive care unit, and we have on the first picture a donning area, and then an entry to the ICU. We have a 4-bed capacity ICU with CCTV monitoring of the patients and the ICU equipment monitors. So we have cameras that are looking at the patient and also at the monitors to minimize the exposure to the healthcare worker inside the ICU. We've not had any patient who has needed to use the ICU, so we don't have an experience of use of ICU, but this is our setup. So there's shower for on the last picture, where the healthcare worker after doffing can shower and then go to the residence. So this is the oxygen supply for the isolation area. So in the first picture, we have the oxygen tanks connected to the piped oxygen, and we have the oxygen plant at the hospital on the other pictures. So one is an employee at the plant cleaning the tanks, and then the bigger outer picture of the plant and the tanks being filled in. So you need a lot of oxygen for these patients. So for the healthcare worker, we have a separate entry and exit, which is used, and you can see it on the second picture. And they have offices which are separate from the isolation area, and they have a tea room and in their office. we have a sluice within the isolation area, which is separate from the other hospital cleaning area. So these are pictures of the sluice room with a machine. So linen is decontaminated with 0.5% chlorine, then washed with soap and water by the machine and sun-dried outside. So these are majority of our patients are asymptomatic. So we have a few patients who are within our isolation area. This is them sunbasking and having an exercise session and a counseling session. Thank you.
Thank you, Dr. Anthony, for that picture explanation. I was taught in undergrad that seeing pictures is more explanatory and you can actually remember more than someone standing there and talking. So as Dr. Inthodeka prepares, we can take the first 4 questions. And the first question, I will direct it to Dr. Joy Mugambi. It's on how the counties is getting coordination between, how the coordination between private and government health care service providers, and what impact and value addition it offers to the common patient and the corona-infected patient.
Thank you very much, Jananga, and thank you to Inda, who has asked that question. I'll give what we are doing within Eldama Ravine, Baringo County. We have ensured every training we do, we involve the private facilities that are within the region. When we seek donations in terms of PPE, we have engaged our private facilities also to ensure that they benefit from that. Yesterday, we actually received PPE from Bata, and this was donated to our facility alongside the private facilities in the area. Partnerships are essential when working also with the private facilities because they are the first people who will receive clients. When the COVID response started and the whole COVID preparedness started, patients started disappearing from public hospitals and going to private hospitals. And with that, we would have missed a lot of cases if only we focused on the public facility trainings rather than also working with the private facilities. So yes, there is a lot of room, and training is very key for everyone in private and public. Inspections are being done by our public health teams to ensure that even the private health facilities comply with all the strategies in terms of protecting the patients who are coming in and protecting their staff against COVID or any other infectious disease that they may be facing. Thank you.
Thank you, Dr. Joy. Sorry, Dr. Joy, another question? Or even Dr. Waina can give us his thoughts on this. What is your thought on telemedicine use, especially for the general remedies of asymptomatic patients?
Telemedicine will be very key. The only challenge, I'll give a rural perspective of where I am, because some of our terrains are very difficult. Some patients may not have the accessibility to networks and telephone services, but something we are trying out is SMS platform. And we want to try out this SMS platform for diabetic patients that we do have. So with that, probably we'll also be able to work out an SMS platform for also the COVID cases. We may not be able to do the WhatsApp, the Zoom platforms, because not everyone has a smartphone, but a kabambe for SMS would work. But I'll also forward that to the other panelists. There's quite an area of panelists, most even in the bigger cities, who can also give us some insights on that.
Yes. Maybe we can have a comment from our panelists, our national governing body, the Dr. Kigondu, Dr. Kitulu can give us a comment on this, on telemedicine use, especially for asymptomatic patients. Dr. Kitulu? Dr. Kigondu?
So telemedicine for asymptomatic patients, I'm not sure what the question is exactly.
What are your thoughts for telemedicine use, especially for the general, for the asymptomatic patients?
Okay, so probably I would look at it in the context of maybe the monitoring. Now that this week we had the home-based care guidelines launched. So the home-based care is meant for those who are positive but asymptomatic. And the step-down approach, I mean, as of up to last week, all positive cases had to go to an isolation facility. So the next step-down phase, which has been planned, is to go into non-hospital institutions, and several of the counties have identified like KMTCs, where asymptomatic positives would be, again, just to isolate them from the community and stop spread, but because they are not really unwell, they really don't need any medical care. Now, further to that then is the issue of home-based care, that even those facilities will get clogged up, and if they are symptomatic and they do have an environment at home in which they can positively isolate and they do not have any comorbidities or things that put them at risk for more severe disease, and they don't have persons at home who are at risk of severe disease, then they can isolate at home. So then from the telemedicine point of view, then that brings in a very important aspect. One, for monitoring, and in fact, one of the platforms, an e-platform called Jitenge, has been proposed to be used for that process, in which the asymptomatic patients can send in their temperatures and any symptoms, so that there's a quick way in which they can identify any change in symptoms. So indeed, that might be, in that sense, the telemedicine is a useful tool to use, because in that sense, if you're at home, if you're in a non-health institution, then you can still get access to care. Of course, part of the challenge around that is that also then that as you align then with the telemedicine front end is to assure that they can link up to a hospital and get care as soon if there's any deteriorating of symptoms happening. For now, I think that is really the way to go in terms of how will you manage their positive asymptomatics.
Okay, thank you. Another question is, I think we can have one more before we welcome Dr. Intodeka. So the next question is on the role of insurance service providers in approving COVID treatment as a cashless treatment or not. What is the general perception of the insurance sector in taking COVID claims? Dr. Kitulu.
Just repeat the question, the insurance sector on the COVID?
No, what is the role of insurance service providers in approving the COVID treatment as a cashless treatment or not? So they're asking the general perception of the insurance sector in taking up the COVID claims.
Well, this week, as it was passed by IRA, the private insurance said they will not even take up any COVID claims. And we've had even a few people this week. There was one who was he was in a quarantine center, identified positive, and he wanted to move to one of the private hospitals. And his insurance said, nope, we shall not be making that payment. So that's an engagement, I think, which even just at the Ministry of Health level, we also at the Kenya Healthcare Federation level, Kenya Healthcare Federation being the health sector board of KEPSA, and of which KMA is a member. That's a subject that actually has been put on the agenda for discussion on Tuesday. There's a meeting on Tuesday to address that issue, because this is not the time in which should be backing out of that treatment. And knowing that in most cases, looking at the statistics we have, most of our patients anyway have been asymptomatic. So if we are stepping down to approaches of managing asymptomatics in non-hospital settings, in home settings, then then they'll be left with those with the severe disease who are the smaller proportion. So that's an engagement that is happening this coming Tuesday. Part of the advisory committee on county preparedness, the Ministry of Health has also called in NHIF to discuss the role of NHIF in taking, covering those, the COVID cases. So there are discussions which are ongoing, but our push really is that all these are things that should be covered, especially when we are looking at the direction of UHC. This is not the time to drop people off. The discussions that will be coming out of the engagement with the private insurers and KHF, we shall definitely be updating members as soon as that meeting goes on Tuesday.
Okay. Now I think we can invite Dr. Ithodeka. Dr. Ithodeka is the consultant pediatrician and medical superintendent of Naivasha County Sub-County Hospital. And she's going to tell us what has been happening in Naivasha and how they've been tackling COVID-19 in Naivasha. Dr. Ithodeka?
Thank you, Dr. Jananga. Good evening, everyone. I'll share with you a pictorial presentation. I hope you can all see my screen. I'll be showing you images of what we've been doing as part of Nakuru County in Naivasha Sub-County Hospital. So we are in this large section of Nakuru County. We have 11 wards, and the hospital is located in Viwandani ward, which is at the top up there. And the geomap layout you can see there can show you what kind of layout the hospital ground is on. And there's a big red cross there, which is intensive outpatient building, which is being constructed through the county government of Nakuru and KenGen as part of their CSR. We're also doing a lot of testing for truck drivers at the Mai Mahiu because of the dry port. And in general, in the last census, we expect that we are managing 300,000 and 355,000 people in Naivasha sub-county. So mostly we are doing a bit of isolation in the hospital and a lot of testing at the Mai Mahiu site. In our hospital, we consider COVID in 6 thematic areas. And I'm showing you a picture of my core team that way earlier on, before the masks and social distances were a major issue. And we're going through the 6 thematic areas that we usually discuss when we're making preparations in the hospital, that include process of how to rearrange the patient flow and triage, issues to do with the isolation unit and reducing the crowd in the hospital. We also discuss supplies and commodities, healthcare worker updates. So majorly the team leading here is the IPC committee of the hospital. And from it, we drew 6 TOT or rapid response team from this team. So when we're discussing process flow of the patient flow and triage, we came up with a rough workflow in the early days of March, where we were thinking about how to set up triage right next to the gate or where the patients enter from, and where we asked them about basic symptoms. At that time, we were looking for symptoms of upper respiratory tract infections, and we're also checking for fever and history of travel. And should they have had any answers yes to any of those questions, we would issue a mask at that point, and then we would take them through a different waiting bay, and they would be seen by a clinician in room 19, whose key purpose was to identify whether they should be isolated in the isolation unit. For the other patients who would answer no to most of those questions, we would proceed with the routine visit through the normal waiting areas. So this is what it visually looks like. So we set up a hand wash station in the top bar up there where you can see the white ceramic area where some ladies are washing their hands. And the security guard supervises that each one is going through the hand wash area. And then initially we had a brown booth here, and we would have the triage nurse at that point asking those questions and taking temperature. And then we realized it was a very open area, and so they were exposed to other elements of the weather. So we now have a temporary top sort of booth that's more comfortable for the health workers, with glass paneling and steel doors at the bottom there. So with the heavy wind or rain, they're able to sit there and do the triage around the clock, 24 hours. We also had to modify other things that were to do with the waiting areas. So we had to do the yellow boxes 1 meter each, so that each patient is able to queue and maintain social distance from the next patient. And so you can see some of the boxes on the lower at the bottom there. So in the second thematic area, we did not have an isolation ward earlier on. And so around March 19, 2020, we repurposed a building that we were constructing to move the CCC clinic. We needed to move the CCC clinic because it's on a current construction zone. And so this building, we needed to repurpose it to become the isolation ward. And so we had to rapidly finish it within like 3 or so weeks. So we had to do the plastering and all that, and painting and setting up the ward. And the latest image we have around April 2020 is at the bottom there. So this is where we keep the patients who are confirmed patients. So we are only a treatment center. We don't keep suspects in our hospital. And the layout internally looks like this. So we have entries at the bottom there, which immediately takes the health worker to a donning room. And there's a door that opens into into the yellow zones. And then each of those yellow zones has 3 beds, and the red zones also have 3 beds on those sections. So we have another door here where we'll separate gender. So we'll put the males in the red zone and the female patients in the yellow zone. Then at the end there, we have a kitchenette and a laundry where we sluice and we clean all the laundry that is within the isolation, and then we dry it outside. So our health workers exit through the green doffing room. And right adjacent to this doffing room, there's a little corridor here that allows us a window access to observe what goes on in the ICU, where we have only 2 beds in that ICU. So we have a total of 13 beds there in that isolation ward. When it came to reducing the crowd, we started considering how to reduce the outpatients. And at that point, we added a tent outside the lab where we had additional seating space. And then we had to, clinics were closed earlier at the point when the directive was to reduce the cold clinics. And then the elective surgeries also were helping with that. Then for mortuary, also restricted to 15 persons per patient. And for inpatients, we only allow the next of kin to visit any admitted patient at a time. We also fast track the patients in the ward so that we have rapid discharge, and we work earlier on. We do active surveillance in terms of those who need waivers earlier. We get to know earlier so that at the point when they are ready to discharge, we don't keep them in the hospital longer. So initially there was a lot of resistance, especially to the visitors, because we were coming from a point where you have 10 relatives and now you only want 1 relative per patient. But slowly the community has accepted that it is a protective measure. So some of the things we did there was to increase some of the benches, and we only allow people to sit at most 3 per bench, but usually there are 2. And the image on your right is showing you the room 19, which has a separate waiting bay, which is partially visible, and it is also partially open. So it provides some type of privacy because for a patient who is seated, and so they will be reviewed by a patient, by the clinician in room 19. For the healthcare workers, which was a major thematic area when we were planning for COVID, we rapidly started training them. We were trained around 14th of March. Were 6 of us, and then we rapidly scaled out the training to the health workers. So we achieved about 215 health workers. That was very early on when the disease was not really not much was known. So we were able to train like in a routine CME without the masks, without the social distancing. And so far we had 215 of the workers in the hospital trained. So we had 2 teams of doctors that received a full 2-day training, and included nurses, CEOs, and lab techs and pharmacy teams. And then we had smaller trainings of security teams and support staffs. Those ones would have like 2 hours, 3-hour sessions where we show them issues that are pertaining to the care that they need to take care for themselves when they're attending a patient. We also had to come up with hospital initiatives because we realized earlier on that we needed to shield the eyes as well. We had no goggles at the time. So we came up with a face shield, which we copied from other face shields we had seen from other samples that we had from University of Washington. So the shield is disposable, it's easy to make, and you use it with a face mask, and you can see Dr. Mungai on the right side wearing it. Then we were sanitizing patients initially in the very beginning when the government directive was for hospitals and churches to sanitize everyone. And we rapidly ran out of sanitizers, so we came up with the hand wash stations. But for the hospital staff, because we need to provide for each of them, we wrote to Keroshe and Mashwa and the DCIO, and we asked them to give us alcohol. And now the pharmacist makes us our own sanitizers, which we issue to all health workers, and we give them small bottles so that they are accountable for it. The last thematic area we discuss is usually the COVID updates. So earlier on, we used to do 10-minute sessions on the Wednesday, 8 to 9 a.m. CME. And that time we were mostly looking at the Johns Hopkins dashboard, and we were looking at how the disease is spreading out over China then, and then onto Europe and to US. And then we're also using the Worldometer site, and the Johns Hopkins website used to have a click which used to link you to the Lancet journals that would give you the latest published journals. So during those CMEs in February and March, we used to just pick issues of interest and would discuss them in the CME. Then when we got the full training, we were able now to replicate it to the rest of the staff. So currently we mostly use Zoom meetings like these ones that are organized by many of the associations in the country. And we also have one we've organized internally, the University of Washington, our hospital, because they are an untapped resource with a wealth of knowledge. So we host the University of Washington Naivasha Hospital CMEs on Zoom on Thursday nights. And usually we talk to chief residents that have been in our hospital, and they give us their frontline experiences managing ICUs in the US, in Nebraska and Seattle and in Texas. And they tell us, things that, how they're doing it differently there, what they think could be better. And we are now at least trying to partner with them to see how we can get other resources like up to date. So I don't have an image of other CMEs. These are much older CMEs that show you how we do the 8 to 9. This one is a clinician's one. We do various aspects. We do the question and answer type of CMEs. We do the PowerPoint presentations. We do case reports by interns. And the most favorite amongst the interns is usually Jeopardies, because usually there are marks and gifts for the ones who score highest. And this is a large crowd pre-COVID time when we were just after a CME, and we are happily leaving to go back to work. So currently we have had about 887,000 patients who have passed through that desk where we triage. And on the extreme top right corner, you can see through the months, March, April, May, and June, the bulk of those patients whom we picked with high fever were in March. But slowly over time, the patients are reduced in terms of percentages versus those we have actually seen. The data for upper respiratory tract infections through those months have been very difficult to correlate and tie together. So we are still looking at how to best analyze that data. So far, we've tested patients in the isolation unit, a total of 19 of them. We had only one positive test, and we've had 55 from the quarantine site in Naivasha. And then so far we've tested 540 as at yesterday. And 6 of those truck drivers turned out positive, and only 4 were in Nakuru County. And so we only managed the 4, and the others were tracked to the counties where they had already traveled to. So we have this building coming up. It's a lovely building. It's a comprehensive outpatient building similar to what PGH Nakuru is going to have. We think it's going to be very important for us in terms of managing COVID-19 patients, and we thank Kengen and our county for bringing this project to us. So currently they are constructing, and this is where we are moving the CCC from. So behind there is also another structure here that you could barely see. You can see with a red roof, and it's an ICU HDU ward that we were constructing using facility improvement funds. So at this point, we are hoping to fast track the finishing of this building, because it directly fits the purpose of COVID-19 in terms of capacity for critical care. At this point, we are discussing how to reopen, and I think we shall proceed with the 6 thematic areas. We shall try and open in a safe way where we are protecting everyone, and we're trying to prepare for surges of patients, and we have to think of an overflow ward, which you could repurpose, or how to open the elective clinics safely. So at this point, this is where we are at, and I would like to conclude at that point. Thank you.
Thank you so much, Dr. Ntodeka, for that good presentation. Today's Pecha Kucha is all about pictures and pictures and pictures. Nakuru, Baringo, Naivasha, pictures, pictures, and pictures. Thank you so much to our presenters for that, for those presentations. There were pictures, lovely photos, and a lovely presentation. We'll go to our questions. And our next question is about how various hospitals across the counties are picking on a COVID test vis-a-vis from red zone, yellow zone, or green zone. Is there any such geographic segregation adapted to cut the community spread of COVID-19? Dr. Super, please. Any thoughts on that?
Oh, thanks, Dr. Janaga. I hope everyone can hear. So I'm just trying to understand that question, saying picking the COVID test vis-a-vis from red zone. I think is the person trying to say community versus hospital-based. I don't know if that's what the person is asking. Or maybe you can repeat it and see.
Okay. The question is how various hospitals across the counties are picking the COVID tests vis-a-vis from the red zone, yellow zone, green zone. Like, where are they picking them up? Or is there any, why the geographical segregation was adopted on the community spread of COVID-19?
Oh,
Yes.
okay, okay. So, like, I'm from Machakos County, and so far, I think compared to Nakuru County, maybe we do not have as much in terms of cases and the screening from the community, other than what is in the hospitals. And in the county, what we have had is the screening and testing within the facilities. And with these, mostly when the contacts are traced, then there's the community identification and picking of the cases. But so far we have, I think, less than 10 cases within the county. And these were people who had traveled into the county. In our bigger facility, like in the level 5, we do not have yet a case admitted, at least as far as I'm aware. But a lot of activity has been happening in terms of the testing. I mean, not testing, but screening the patients. We have been doing testing within the main hospital because we have a lab that is able to do the PCR tests. And from the other facilities within the county, they have also been sending the samples there. So I don't know whether the part for the geographic segregation, whether they mean that, you know, the separation within the hospital or community. Probably Joy can give an input on that, because she has a lot more experience in the community.
Dr. Joy, comment on that?
In terms of putting okay, I know I've seen the question in terms of even how we are ensuring we don't end off in the community as well as the testing. When we go into the community, we mark an area within the compound of the suspect that we have gone into. And we create an area for donning, and then we create an area for doffing within the compound. We also are accompanied by the public health officer with a hand spray pump that they use to disinfect the area, inclusive of the area where the client has walked from the house to the compound. In terms of that question was a bit vague, and that is why I think even Super has had an issue going through it in terms of red zone, yellow zone, green zone. I know I have seen Idondeka having had a presentation where she had shown red zone, yellow zone, and green zone, and I think this was targeted to her presentation. So I'll hand that question back to Idondeka to be able to answer how various hospitals across the counties are picking the COVID tests vis-a-vis from red zone, yellow zone, green zone. So I saw you having put zones within your isolation, Idondeka. How do you test those different patients?
I must start by clarifying that initially what we thought was the yellow zone, we thought we would keep suspects in the yellow zone. But we later revised because we understood from the WHO online, you know, how to set up structure, I mean, IPC wards. We discovered that should we put suspects in a place where they even share a washroom, then you essentially create contacts. So we repurposed our center not to have suspects anymore, but to only have what we call confirmed patients. But in the beginning, we had imagined that for like how the Nakuru layout looks like, the suspect will be in their own zone, and that zone we perceive it like it is still part of the yellow zone because they may or may not have COVID-19. And then the red zone is what we were perceiving as the suspected area. So for the tests, when you're entering anything beyond the yellow red zone, you'd have to have full PPE. But then the green zones, you could have partial PPE dependent on what procedure you're taking. I'm hoping I'm answering the question correctly. Yeah, so I think that's the best I could answer.
Yeah, thank you. But I also thought that the question was a little bit vague, but because what they meant is from the community part of it. So I thought they wanted an explanation of you identifying a case from the community and zoning it as you go outside the community. That's what I thought they wanted, but the question was not really clear. So thank you, Rebecca, for explaining it from the hospital aspect. Next question. This is to Dr. Wainaina. So Keegan is asking, I guess Nakuru has discharged some few cases now. Have you done any care costing? If so, on what patients?
Hi, Keegan. We've not done any costing at the moment. The patients are being treated for free, and the cost is being taken up by the government. So for the costing, what I would say is we have rational use of PPE, where we have PPE use based on the risk of contracting the illness. So let me share this, please. So this last picture that I showed you, you have different type of PPE that you use for patients. The healthcare workers here are wearing gown, gloves, head mask. They have their own scrubs, and they have a mask, and they are keeping a huge distance. So there are points in which that you can use the full PPE, the hazmat suit, and the N95 mask, and there are points at which you do not need to use all that PPE, and this will save on your cost. So an aerosol producing procedure, for example, intubation, maybe ventilation, suctioning, some procedure where you are in close contact with the patient, maybe fixing an NG tube, you need to have an N95 mask or the full hazmat suit with the N95 mask. But if you're doing a procedure which is not aerosol producing, so for example, if it's a nurse who's going in there to give an IV antibiotic or IV fluids, or to maybe just take the vital signs of the patient, or just to clerk the patient, you don't need the full hazmat suit. You can use this. You can use a gown, gloves, and the face shield, protect your eyes, and the N95 mask. Also, you need to for example, if a patient has moderate disease, pneumonia, has acute kidney injury, you can dialyze the patient using this minimal PPE. But if you have to resuscitate the patient, then use the full hazmat suit. This will lower your costs. Then we also limit the healthcare workers who go in to see the patient. So for example, if you're giving meals and giving an IV antibiotic or IV fluids and taking the vital signs, all this can be done by one person. So everybody will come and give their input on what they want to do, and then one person can go in and do all that. So you'll minimize the use of your PPE, and you also protect a lot of healthcare workers by minimizing the number of people who are going into that room. Thank you.
Okay. Thank you, Dr.
Thanks, Naina.
Anthony.
Before you bring down that, before you bring down that last slide answers the question that Mahava has asked in terms of psychosocial support. One thing Dr. Wainaina and team have worked through, he's not told you much about from the very first client up to the time they got extra clients, was they really realized that there was need for psychosocial support and also getting their clients active outdoors, because staying in a confined area is quite distressing and can also compound the stressors that these patients who are coming into their isolations are having. So yes, they started this physical activity exercises for the clients in the isolation wards. And you can see they are protecting themselves, and the patients have also covered up. And that has really offered the psychosocial support that Mahava has asked about for the clients. For the OPD clients, our normal essential service clients who come in, yes, there has been a lot of questions about the anxieties they are facing in terms of COVID economic crisis. So what we do in Ravin, we do have a mental health nurse who does morning talks to the clients who have come into the facility. We have an outdoor compound, like what this isolation area is. It's some grass and some benches placed. So the clients who come in, they are taken through some psychosocial support discussion. They talk about their situations and they debrief a bit before we start our clinics. So this has really helped. We purposely also ask our clients about what they are facing at home and have further discussions. Where we can, we refer them now to the psychosocial nurse who offers further counseling and support. So there are organizations in the country who are offering psychological first aid training. The national government has a guideline that they sent out for health workers to be able to provide psychological first aid, and that guideline is in their website. It's called the Mental Health Guideline during COVID-19. Do access it. It's also in our Facebook page, in our website. Access it and try go through it and be able to assist a colleague or even a client that is coming in before you refer them to the psychiatrist. Thank you. I hand back to you, Jananga.
Thank you, Joy, for that. Joy has been doing a lot of psychosocial counseling and of both the healthcare workers and also the COVID affected patients. Thank you so much, Dr. Joy. Now, I would like to welcome Dr. Wainaina Daniel. Dr. Wainaina Daniel is a representative and a county health representative from the Nakuru County. And want him to give us what the county is doing and how far we are with COVID-19 in Nakuru. Dr. Wainaina, are you there, Dr. Wainaina Daniel?
I think he'll be represented by Dr. Itondeka, and he sent in a small presentation to share in terms of the data for Nakuru County. So Itondeka, you can take us through.
Okay, thank you. I think so far in terms of Nakuru County, you can see Dr. the screen that Dr. Joy is sharing. So we've had a total of 2,022 patients who've been tested so far, including contacts to confirmed cases. And so far, the suspected patients we've tested are 260. And for the truck drivers, as I'd said, were 540. We've also been testing health workers, who are about 424, and food handlers, mostly in the hotelier industries. So I would say that so far, 19 have come out positive, and 10 have been from local transmission, and 7 were importations. And I think majority of these were in the quarantine areas. We've had 3 recoveries and discharges so far. And in terms of the admissions, we have 7 in PGH Isolation Center, and 2 of them were also truck drivers that were tested in Malaba, and 1 Congolese national, and 1 in Naivasha Isolation. We have about 388 out of the 422 contacts who have been traced and followed up, and the response rate is at about 92%. 307 of these have been discharged after successfully completing their 14-day waiting period, and we still have the rest, about 11 persons in the Kitty Quarantine Center. We also have quite a number who are in home-based isolation, and there are 70 of them. So far, I think the major thing that we are doing is surveillance and screening of the long-distance truck drivers and other passengers between the Kiambu border and the Mau Summit border. And I know we use the sub-county team leads in these borders, together with the policemen at the border points. I mean, at the police checkpoints, to do aggressive surveillance of the people on transit. We collect samples and test the truck drivers, specifically in Mai Mahiu, and we had suspended it temporarily earlier in this week because we had run out of reagents and some testing kits, but we resumed. And I must say that our waiting period for Mai Mahiu, the lab is much shorter. It's about 12 hours to 24 hours. We are able to get our results. In terms of risk communication and passing key messages, it is ongoing, and we are using this with collaboration with various partners. And we also are employing the door-to-door using the community health volunteers. And we have been having people coming in from Mombasa and Nairobi metropolis through undesignated routes, and this has been a cause of concern and has remained a challenge for us. But most of the communities right now are quite sensitized, so they are able to raise those alarms, and sometimes they raise them through the policemen or the chiefs, or sometimes they call the hotlines, or other times they call the community health volunteers whom they may be in the same areas. And when that happens, we are then able to identify those people, and we do visits, and we do aggressive surveillance to understand what situation we will use to manage those patients. I think that at a glance is what Nakuru County looks like so far. I think we have very good support in terms of our county government of Nakuru. We have a very able governor. He is very pro-health from what we have seen. And so much of the major infrastructural and human resource issues are very well addressed. And then also the partnership with national government assisting us where we need, especially the testing, has been quite remarkable. And I think the organizations like KMA have been very instrumental in making this happen. Yeah, so I think so far this would be what I would say is the Nakuru County report. I think I'll hand it over back to Joy.
Thank you very much, Dr. Ivandeka. She was representing Dr. Wainaina. I did not know, Dr. Wainaina, you are on the attendee
Joy,
end.
may I interrupt you? Daniel seems to be here now.
Yes, I have added into the panelists. Dr. Wainaina, welcome very much. Dr. Wainaina is the County Director of Medical Services, Nakuru County. We truly appreciate the collaboration we've had with Nakuru County as a division. We are sitting in the COVID response team for the county, and we have worked together in planning and ensuring mitigation of COVID is done in collaboration with them as a partner. Welcome, Dr. Wainaina. At least even just say hi.
Hi, how are you? I didn't realize I joined among the others, but it's good to be a panelist now. Just to say that the report that was presented by Dr. Idondeka, very ably so, was as for 2 days ago. There's been an update. This evening we discharged 3 more patients, bringing the total of those discharged from Nakuru County to 6. And the cases that we've diagnosed so far, those who have passed through our facility are 10, but we've had 12 positive cases. Unfortunately, one of them was diagnosed in Kijabe, having left Subukia sub-county and passed on shortly after admission. A middle-aged man who had comorbidities and was buried today in Subukia. So I think the rest of the things have been said by the other presenters. Thank you.
Thank you very much, Dr. Wainaina. I hand back to Dr. Jananga to welcome Dr. Tara. We know we may not be able to answer all questions, but any question that is so intense, we will ensure the panelists do respond to you on your emails. Thank you. Dr. Jananga.
All right, thank you so much, Dr. Joy. As she has well said, we will not be able to answer all questions because of time. So with no much ado, I'll welcome Dr. Otara. Dr. Otara is our former KMA chair, Nakuru Division. He is a consultant gynecologist, obstetrician and gynecologist in Nakuru. He is also a senior lecturer at Egerton University. Dr. Otara, before you give us your closing remarks, please give us a comment on the public-private partnership. What are your thoughts?
Thank you, Dr. Jananga, and I really want to appreciate the organizers of this event. It's been really nice, eye-opening, and interactive. I'd wish to participate in many more Pecha Kuchas as we move forward. The presenters, you've been wonderful, and I think probably I may have a word on each of their presentations. To start with, I think difficult situations like this are the ones which bring out true leaders. As from the presenters, they really stood out as true leaders in every aspect of the word. It's not that you want to celebrate on top of the COVID situation, but I think starting from Dr. Itondeka, what you have given us is just truly a sign of dynamic leadership. Moving on to refashion, structural things and places to take care of, or in preparation for the COVID response. And I think it's hats off for you and the team that you work with at Naivasha. You moved with speed, and I'm happy that you even taken up technology to use for your education and CMEs and training for your workmates. It's really impressive. Of course, the only thing, as Joya said, in your team, as you listed, the one person that is crucial, that is missing there, is the counselors and the psychological aspect. But really, Naivasha, you stand out, and I think it's great. In terms of what Anthony, the expert, has said, I know the kind of work he has done, particularly at the PGH, in taking care of the patients and giving direction on standards and care and protocols. I mean, it's also very impressive. Anthony, keep it up. It's work that he started, and I'm sure we are going to learn a lot more as time moves on this particular aspect. Even the aspect of exercise and counseling, and really bringing out people who are asymptomatic to vent out, to exercise, because the 14 days in isolation can be really, really difficult. One day for any of these doctors here in isolation will be so heavy. So those innovations come out and really, I think I really appreciate what you've done. For Joy and what you've also done in Eldamaravine, it's quite a lot of leadership, but there are a number of learning points that I've really liked in terms of what public-private partnerships can bring out in health, the innovations that you have adopted to use in the care, in the preparation for these kind of scenarios in the community, all the way to the hospital. As I said, COVID was new. As she also said, COVID is just new and nobody really quite knew how to handle it. So all sorts of things have been used, correct and wrong. And probably let's not wait until the end to do our postmortems. There are few things that I think we have learned in the course of it. Like what Joy has presented is a very good model on how to handle this kind of diseases which come from nowhere. You know, the model that I think this country we adopted was we started using the police and the people called public health technicians and officers who were shunted a bit, and then the community comes in last. And I think that's a model that I think has its challenges, and you can all attest that very few people want to come out for testing, because the way COVID was introduced was in terms of quarantine, isolation, everybody ran. But if you listen to Joy's presentation, they started with public health. The public health people went out to the community, and then finally the police. You know, it's really, I think, sounds like what we need to adopt from the COVID thing. Let the public health officers, technicians, and personnel be the leads in terms of this exercise, and move on to the community and then bring the policing aspect. It was a new disease. We have to learn our game through this, and I like the way that model that is working in Naivasha. In Eldamaravine. Then finally, on the issue of what KMA is doing in the whole thing, our leadership, the NEC, I think, you stood out, we appreciate, and the inputs that you've given all the way from the CORAC into the MOH, the task force, doesn't go unnoticed, and KMA for once, people may not appreciate you. You may be looking like you're in the background, but for those people who know what's going on, it's a lot of work that you've done to inform policy on COVID response and everything. And keep it up. I'm sure there will finally be light at the end of it. The challenge in private hospitals, probably thinking about it like in Nakuru. The private sector involvement at the initial was not so much. We concentrated more on the preparation at the public hospitals, and information didn't trickle down to the private hospitals, and there was a lot of panic at the initial. People didn't quite know about what even PPE was. I saw a situation where there was a suspected case in one of the hospitals, and people were freely, the sweeper was really doing the routine cleaning, that somebody was feeding the patient as usual, but within a short time, and thanks for the intervention of the Director of Health Services, Dr. Dio Wanaina, who is there, they moved, and I think as we talk, even all the private hospitals in town are up to speed on how to respond to these situations. That said, I think there may be some few challenges in terms of private hospitals, in terms of the availability of their PPEs. We hope they'll step them up. There are issues definitely that have happened over this time. Yeah, the economy has gone down. People have less purchasing power of health, even including health services. And most health facilities are actually been hit hard. Private health facilities have been hit hard. The insurances are not paying their monies. The hospital, NHIF, has also not paid their monies. And so there are definite job losses. It's really a pity that we can be talking about job losses in times of pandemics when you expect the health worker to be the most crucial person. So to me, I think that is the biggest challenge that we all need to re-engage and see how best can we cushion the private health sector in these times of COVID, including even lobbying the central government still on their stimulus package to not just to think about the hotels and the other industries that are collapsing, but the main industry against disease and COVID will be the hospitals, both private and public hospitals. I really think those are the main points that I picked from this wonderful discussion. And that may be my small perspective about the public hospitals or the private, facilities in terms of their preparedness for this. So I hope that catches what you're asking, Dr. Liz.
Okay. Thank
Hello?
you so much. Yes. Now you're back. Thank you so much, Dr. Otara. Yes, you were breaking towards.
Not on.
No, you were breaking towards the end.
Aha, sorry.
Yes.
But I hope you got the point in terms of cushioning the private hospitals at this time may take quite some interventions all the way from the task forces that are working on preparations for COVID. And it just doesn't affect COVID. There are other conditions, diseases, comorbidities that need to be taken care of and may be affected if the public or the private hospitals do collapse at this time.
Okay. Thank you. Thank you so much, Dr. Otara. That was Dr. Otara, a former chair of KMA Nakuru Division, and is one of the contestants for the next vice president of National KMA.
Oh.
He actually forgot to pitch for himself in terms of. In fact,
imagine.
Well, the moment I was given was to talk about private hospitals, but now that I realize that the other task I have in front of me, of course, definitely I want to thank the team in Nakuru that have made this possible, and the team that supported my tenure as the chairman in Nakuru, and we did grow in steps and strides. I really want to appreciate you guys. And in the next task that I'm seeking support from whoever is in this gathering and the membership of the Kenya Medical Association is that I'm standing in for, I want to stand for the post of vice president, national vice president for the Kenya Medical Association, so that one, we can build on the leadership that I've already attributed to. There are a number of challenges, of course. The position of KMA needs to be up there. Everybody needs to understand that we are the custodians of health in this nation. We should show leadership in terms of policy and even all the way to professionalism in practice. We will enhance issues of advocacy on various issues, including what I've just talked about, budgets, allocations. You've already seen the budget that was read yesterday. Of course, there's a slight improvement in terms of allocation to health, but it still falls far below what anybody could have expected, particularly at this time of COVID response. Here is a situation where you are talking about 111 billion shillings allocated to health, just a drop really far below what the 15% that we've always shouted for. Even if you added the small, about 50 billion that goes to the counties still on health, it is still a sub 10%. And that is one of the things that probably people need to be re-engaged to understand that health is wealth and the government needs to do something about this. You can see we have adopted the ICT and IT technologies and we are able to communicate face to face. You can see the leadership Nakuru has taken in terms of this, and these are things we are promising to take further to another level if we are given a chance to provide this leadership. Health across the borders amongst our professionals, all the seniors, linking up with the younger doctors, and even the doctors in training is another of those aspects that I think we need to really engage, because we need to shield this profession and bring out lots and lots of professionalism. It's a short time. I'd wish to have more time together with all of you, but for real, I have the heart of Kenya Medical Association at heart, and together we will build a lot more and gain a lot more, mobilize more resources, fundraise more for this organization, so that even our membership can rise. As it is, we are about 10,000 doctors registered by the council. The union has about 3,000 membership. The older association that we belong to, as that now we are hardly, we are struggling, we are filled up to 1,000 plus, and that is not the position you want to occupy. I don't want to take your time, it's late in the night. Thank you so much. Please for giving me that chance.
You're welcome, Dr. Otara. That was Dr. Otara. Now we've come to the end of our today's Pecha Kucha from Nakuru division. And I would like to welcome the speakers to give us their closing remarks. And yes, Dr. Joy, any closing remarks?
Mine is to say thank you very much to the attendees and to the panelists who joined me tonight, and our National Executive Council for also being part of this. We look forward to the next Pecha Kucha. We don't know which division it will be, but join us on Friday as national office and find out which division will be in. And we hear what other divisions are doing. We never know what we will learn from them. But my take home from this as we go ahead, please do not forget the community. Communities have solutions, and use those communities to help you come up with solutions. We would rather not bombard them with our solutions, which are so technical, but let's find solutions also from the community, which are simple and doable.
Thank you, Joy. Dr. Anthony Wainaina, any closing remarks?
Thank you for the opportunity to present. My final comment would be maybe to embrace home-based care for the asymptomatic patients or the patients with mild disease. If the patient can get an area that they can be isolated, and these patients need to be in place where they don't have elderly patients, very small children, the pregnant mother. They also need to not have comorbidities. But if we have this patient, they can be isolated at home. They have basically, I wouldn't say we are not doing anything, but for the patients, we need to consider this. I think it's a good approach to managing the numbers in hospitals. Thank you.
Thank you, Dr. Anthony. That is for patients who are asymptomatic of mild disease. Dr. Intodeka, any closing remarks?
Yes, I'd just like to thank KMA for organizing this Pecha Kucha. It's very different and very helpful, I think, to see images from other areas. It's a world of a difference from the graphs and texts, so the messages sink in better. I also think it's important that we use this time to try and fix as much of the things we've been campaigning for in health. This is a time to ask for those ventilators, those equipments, okay, those things that you think have been a bottleneck earlier on. I think this is also the time to come up with various innovations and solutions that are much more sustainable, and let's adopt a new way of living even for the health sector. Thank you. Thank you for attending and listening to us.
Thank you, Dr. Ipadeka. Dr. Wainaina Daniel, any closing remarks?
Yeah, thank you very much. I want to thank everyone, to thank KMA for creating this forum for us. And I think we are very glad to participate as both as as a KMA member, as a part of the government and part of the family, the most important family in this world, as this pandemic has proved. I think we must look for opportunities to put health in the prominence it deserves as we move forward post-COVID times. Thank you very much.
Thank you, thank you, thank you. Thank you to all our presenters, our speakers tonight. We also want to thank the panelists. On our panelists tonight, we had the chair, the current chair, because we've not had elections, the current chair of Kenya Medical Association, Dr. Kitulu. Thank you so much. We also have the president. We also have the Secretary General, Dr. Kigundu. Thank you so much. We also had our treasurer, the National Treasurer, Dr. Super. We also had other panelists from Nakuru who are in the Nakuru division, heading the Nakuru division. We had Dr. Evelyn Mulwa, thank you. And yes, and our former chair, Dr. Otara. We also want to thank the attendees for your questions. I'm sorry we were not able to answer all the questions, but we'll communicate and give answers to those who asked the questions. And want to wish you a lovely evening and a Pecha Kucha evening. Thank you. Bye-bye. Good night, everyone.
Bye. Thank you. Okay.